Thank you very much, Mr. Brown. Mr. Lamborn, you were also in the meeting on Monday. You're recognized for 5 minutes.
Thank you, and thank you, Mr. Chairman, for being there, coming from Florida. And I want to, first of all, recognize Representative Kaufman and his foresight and leadership. When he was first saying the Army Corps of Engineers needed to be brought in, a lot of people didn't believe him. And yet here they are now, literally sitting at the table. So I appreciate that. Secretary Gibson, we are all very concerned about the cost overruns and the time delays with the Denver hospital. Can you reassure veterans in Colorado that the time delays will not prevent veterans from receiving the health care that they need in the meantime?
As I mentioned during my opening remarks, the Eastern Colorado VA healthcare system continues to provide great care to veterans. Most recent number, probably the month of November, December, 64,000 outpatient appointments completed during that month. 92% of those appointments completed within 30 days of when the veteran wanted to be seen. Still not good enough, but it tells me that there's an awful lot of great care being delivered there. We're also ramping up both choice and also referrals to care in the community under VA's traditional non-VA care. So we are committed to delivering to veterans right now and for the interim period of time the best possible care.
Okay, thank you. And for either one of you, and we've touched briefly on this, but when specifically will we know the final and best estimate of the cost overrun so we on this committee can begin the difficult work of identifying funds needed to bring the hospital to completion?
I'll try to answer that and then defer to the two experts here. The process that we're going to have to go through here, and this was a topic of robust discussion just yesterday with the senior leaders at KT, in a contract negotiation, typically price is the last thing that falls out of the process. And so we're applying a lot of pressure to our teams to dig together collaboratively to provide as much information as early as we possibly can. But I think the general time frame, some clarity several months from now is going to be about the earliest I think we can hope to have a good idea.
Okay, several months from now, and that's as specific as we can be right now.
That's as specific as I would want to be, yes, sir.
Okay. And I know you don't want to get ahead where wrong figures are thrown out there creating false expectations.
I think one of the biggest problems we ran into in this project is we tried to push to a firm target price before we had everything locked down. We rushed to get there. We were anxious. We were impatient. I think a lot of that probably had to do with the fact that it had taken forever to get to that point anyway, and so everybody wanted to get on with it. And I think that's why we find ourselves sitting here today.
Okay.
I want to do this right.
Exactly. And I understand that. I mean, we are eager to move forward, but we want to do it right.
Yes, sir.
And lastly, for either one of you, has the VA considered developing a standard hospital design template in light of all the current major construction overruns that could be used throughout the country with only minor local modifications, which would, I believe, potentially save tens of millions of dollars on each project?
Sir, I'm happy to say that we have begun that program. We look at our clinics, our leased clinics. We've developed some standards to go forward. One of the things that each one of our medical centers has is a unique program of services that they provide to the veterans. So, correct, yes, sir. So what we're looking to do is develop templates that we can then say, if we've got a 1A hospital with 10 operating rooms is the workload, this is the configuration or template that we would use. And then by adjusting the adjacencies, looking at the physical constraints of the site, we can then build the building blocks that cut down on the design effort, cut down on the customization, if you will, and develop that better value for the taxpayers. And this is experience that we've learned from the Army Corps of Engineers. They've done it with barracks, dining halls. They're doing it with some of their facilities. We work hand in hand with them on our space and equipment planning programs so that when we program out a hospital, we're using the same kind of background information that they use also. So this is something we're also looking at our other partners within the federal space and within the other medical communities to make sure we get hospital templates that can be delivered, that we can cut down the design effort, because one of the things that cuts down on the change orders on the back end is something that's important, an important driver. It's speed to delivery. If I can cut down the distance between when a project gets visualized and doctors come up with their requirements and delivery of it, we cut down on the amount of change and turmoil that goes on in a project.
Okay, thank you for being here today. Thank you for being in Denver on Monday.
Mr. Takano.